Hello, I am really excited to be here today, get an opportunity to speak to everybody about what I'd like to refer to as new Hines. We've been familiar with Hines for the last 30 plus years. We've had a long run of some excellent service, and in the last year and a half there's been acquisition. Global Excel acquired Hines, and with that came a lot of new capabilities and new opportunities. So today I'm pretty excited to talk about a specific case that kind of showcases exactly how we were able to put everything together and deliver the best of what I refer to as new Hines. With that, I'd like to introduce a very expert group of people that you may recognize and some new faces perhaps. So Sharon Cody is COO of Hines. She's been with us for 30 years, heart and soul of everything that we do, and brings just a wealth of knowledge and experience and compassion to our care management. Farrell Ladak is probably new to many of you. She is our CMO, Chief Medical Officer for Global Excel, learning a lot about Hines and enjoying the experience. And Fiona Fiquette wears a couple of different hats. She's a professional coder, but on top of that, she's a negotiator who has been negotiating with the Global Excel group for going over, 13, 14 years now, and just amazing insight into the financial side of how claims evolve. So I'm really excited to have everybody here today and to talk through a case of a specific individual. Obviously PHI, we're not going to be able to share with you real names, so we're going to call her Mary, but Mary was a very interesting case that kind of came across our collective opportunities, and I figured I'd throw it over to Dr. Ladak to maybe give us just a little overview of Mary's medical situation and kind of what happened.
Love to. Thank you. This is a really complicated case, and it kind of puts a whole bunch of problems into one case, but it's very interesting too. This is a 61-year-old lady who was actively working and was moving some heavy boxes at home when she felt she strained her back. She went to see her doctor and was given some pain medication and told to stay a little bit more sedentary for a couple of weeks. She has a history of hypertension, diabetes, hyperlipidemia, and obesity. She also has a history of herniated discs and has had 2 previous steroid injections in the past. So he'd set her up to see her orthopedic surgeon in a couple of weeks, which makes sense. Unfortunately, the day before she went to see her orthopod, she developed severe shortness of breath and lower extremity swelling. She went to the ER and was found to have a big blood clot, a pulmonary embolism, and in her lungs. And they did investigate to see if she had a blood clot in her legs, but she didn't. They put her in the ICU, started her on blood thinners, but she deteriorated, and they realized that she was hemorrhaging from a gastric ulcer. Most likely what happened was that over the last few weeks, she'd been taking some anti-inflammatories. Then the side effect of that is that they give you ulcers. Well, not all the time, but once in a while. And unfortunately, when somebody starts a blood thinner, that can hemorrhage. And she went into shock and was really very sick. They had to actually have interventional radiology do an angiogram and a coil embolism to the artery that goes to the stomach. This is not a common procedure. And in fact, Hines made sure that this was appropriate and approved. They used their specialty physician to do this. She got better, and it took a few days, and she seemed to be getting to the point where she could go to sniff, and we started to work on getting her a sniff bed. However, just before that, she complicated yet again and had a stroke. She had bleeding in her head. And unfortunately, this meant that she had to be reintubated back in the ICU, restabilized. And this took a few more days. Finally, she got better and was getting ready to go to sniff again. She managed to pass the swallow test, which is a test to make sure that she can eat and swallow without aspirating, because that's not a good thing to happen. And then she went So she passed that and she was ready, and they were finding a bed for her. And unfortunately, just before that, she was found to have a big blood clot in one of her legs. At this point, they needed to put a filter in the inferior vena cava. What this does is it prevents the blood clots from going to the lungs or the head, which she's already had one of each at this point, and it protects her. Um, uh, well, it seemed like we were going on a good path, but unfortunately, she then developed blood in her urine. I know I'm not making the story up. It's incredible. She was found to have a cancer in her ovaries that had already metastasized and was causing problems in the lower part of her abdomen. The problem is that at this point there was so much metastases and so much disease that she was really not a candidate for surgery right away. Plus she'd had such a complicated period, last few days, there was no way she could go to the operating room. So they decided that she needed to be rested, her pain needed to be controlled, and once she got a little bit stronger, perhaps she could have some chemotherapy, because then what you can do is try to shrink the tumors down and then look and see where you're going to go. So we were, again, instrumental in quickly getting her to sniff and getting her the care she needed. Why is that important to move quickly to the sniff level? It's not only important for financial purposes, but it's more important for the patient, because when you get to the sniff level and to some palliative care, they are more interested in helping you, the mental, the physical person, to help you manage your pain, to get out of bed, to get stronger. Whereas in the hospital, we're all running around trying to cure you, to see what's wrong, order more tests. So there's a different mindset. And once you get to the palliative care, the sniff, you get this other holistic kind of approach. And this was very useful for the family because they were shocked. The last 10 days to 14 days were incredible. I mean, they went from a wonderful, healthy, working human being to somebody who's in this kind of state. And I'll stop there, Steve, and let you ask some more questions.
So I'll pause a little bit from a medical perspective, because you're very familiar with some of the lingo you were using. SNF, can you tell me what SNF is? What does that stand for, and why? You touched on why it's so important, but who staffs a SNF, and why is that group different?
Okay, so a SNF is basically like a step-down unit. It's a nursing, it's a level of nursing, really, and you have a doctor that usually works with them. So, but there's not all of the investigations and all of the other stuff that goes on. And then the palliative care part of it is that you actually have a team that's responsible to make sure that their pain is addressed, that all the needs that they have are addressed. So this is a step down. It's not acute care. It's a skilled nursing facility, as what the words stand for, SNF. Us Americans, we love to have acronyms for everything. So this is just another.
Thank you for that clarification. And I'm obviously, I'm just in awe of this case. It sounds like almost everything that could have gone wrong for this poor woman and her family did go wrong. At that point, what was the prognosis? How did things look medically? This doesn't sound like there was going to be a good outcome.
No, and unfortunately there wasn't. But the good thing about it is, even though she actually continued to get worse, and they had to actually put her in hospice care, her pain was controlled, the family was supported, and the next part of her journey was not rushing back to the hospital for further care. We managed to avoid, whenever there was a crisis, avoid being pulled back into the ER and having a few more days of admission, because that's what tends to happen. Someone has a crisis, and if they're at home and they're without those services, nobody's there to deal with them, and everyone's scared that they're not doing the right thing by the patient, so they just dump them in the ER where they're extremely uncomfortable. They're back in this crazy milieu, and it doesn't work out. So her last few days or last week or whatever that was peaceful, well controlled. The family was supported, and you can't ask for a better outcome if that is the only choice you have, unfortunately, and that was her only choice.
My mother went through hospice care, and I can remember just the nursing, the staff, the compassion, the care, and it's never an easy process to go through, but having those people around who had seen this process over and over and knew what to expect could help the process be as easy as it could be was remarkable. And I think that speaks nicely to Sharon and the team on the case management side. At that point, early on, we had an opportunity to get involved, utilization review, obviously, and then case management, and see it all the way through. And there's kind of cracks in those different transitions of care. Can you talk to us, Sharon, a little bit about what did Hines do? How did we get involved, and how do we smooth over those cracks?
Certainly. Hines became involved in this case when the facility contacted us to initiate certification of the admission. So it was the day after she presented to the emergency room. So the utilization review team, requested more records so they could get a clear picture. And that triggered in that same day a referral to medical case management. It was pretty apparent that this woman was going to have some ongoing needs. So the referral was timely. Simultaneously, UR was actively working on looking at the status of the facility, which happened to be out of network, and working through that side of the complexities in this case. Mary was, actively working, enjoying her life with her family, and then her world got turned upside down with this admission and one crisis after another. When she was admitted, she was put on a ventilator within a few hours, and actually was on the ventilator, I believe, for the first 8-9 days. But case management was effective in connecting with the husband and developing a rapport. Actually, was also introduced to the adult son and was able to provide emotional support and education through this course of hospitalization, where one new diagnosis and illness was uncovered after another. While UR was uncovering that this hospitalization was out of network, case management got involved and communicated with the TPA to see exactly what was the status. It was confirmed that there was a RAP network that was available to provide a discount for the hospitalization. However, they reported that the discount was inadequate. So at this point, we initiated the referral to the negotiation team to assist us in handling this claim. There were other complexities that occurred in this case. The woman was admitted. The hospital had an alternative payer source listed as her primary payer source, and her employer group health plan was listed as secondary. As case management continued to investigate, that alternate payer source was denying benefits. Yet her employer was waiting for the coordination of benefits paperwork to be returned to the TPA so they could process and release benefits. So there was definitely some unique things going on behind the scenes in determining payer status. And that was really hanging up any effective discharge planning that was going on. The hospital was getting turned down as they would attempt to make referrals to skilled nursing facilities because no one would step forth and guarantee benefits as a primary payer. So case management simultaneously initiated paperwork to apply for Medicaid to have a backup alternative payer source. And that smoothed the way. We did find a skilled nursing facility that would accept this member. And we had that available and continued to coordinate throughout her highs and lows of this inpatient admission.
I'm hearing you talk a lot about stuff that goes on behind the scenes that, really the patient, but I think probably her husband, who was more aware of some of this stuff, didn't know that all of this was going on. There was approvals. There's, I don't remember. I think this, if I recall correctly, this might be an employer group, a school, something like that, and there was probably a stop loss payer involved. Can you talk to me a little bit about, all that invisible part that Hines took care of, so that the husband didn't have to worry about this, as he was worried about his poor spouse going through all of this?
Absolutely. At utilization review, as they uncovered it was out of network, and the facility reported that they still were paid as in network through this alternate wrap network, triggered case management diving in deeper to work on that. On the third day of admission, utilization review sent a shock loss notification letter to the stop loss carrier to alert them of this high claim potential. So we initiated that communication to that layer. And as I said, we were looking at trying to solve the mystery of who would accept and release benefits, so we could timely coordinate that step down to subacute level of care.
It's amazing, all of that work that kind of happens. And talk to me just a little bit about, what does it mean if I am in the hospital and I could be stepped down, but I'm not? Why would that be a bad thing or a good thing in this case? Can you talk to me a little bit about that?
Certainly. The subacute setting is the setting you want a patient to progress to timely, not only for the cost. It is a far lower cost than staying in the acute hospital. It also does serve the patient best, moving them along, getting them mobile, helping her recover, and work with therapy and get stronger and be able to transition to whatever care is deemed appropriate for her going forward. During the course of the hospitalization, her symptom management, the needs for pain control and to address other symptoms was pretty constant. So case management started discussions on palliative care early on the admission with the husband and the son, to help them to educate the family on palliative care, to understand that palliative care is there for symptom management, to be able to access that approach, whether it was in the hospital setting or whether it was in the subacute setting. Subacute level of care is very important in a patient like this who's had a roller coaster of events. She was debilitated, she needed therapy, she needed symptom management, and she needed a palliative care approach that was able to be coordinated once she was transitioned to that skilled nursing facility.
I guess in my mind, we had a very unfortunate case, and there was a lot of work that was going on behind the scenes. And at a certain point, you identified that this was an out-of-network claim, and that there was, I think, a 50% discount, if I recall correctly, in play with whatever the usual wrap network would have been. And you said, hey, let's engage our cost containment unit to have some negotiations. And so at that point, I think you reached out to Fiona and team. And Fiona, maybe you can talk to us a little bit. You get one of these cases, you get Mary. What do you do? How did you approach that? What was your process?
Yes. So in this case, Global Excel's negotiation team were notified about Mary's case during admission. After Hines determined that this was an out-of-network claim and were granted approval for negotiation from the TPA. So one strategy for effective cost containment begins with negotiating pre-service or prior to the claim being submitted, which is what we did in this case. Engaging in negotiations early on increases the chance of success, but experience also matters in knowing who to contact at the facility's business office, as far as the CFO in this case. It also involves relationship building or even leveraging past relationships to engage early on. I think that's key to secure the right discount during that outreach. And Hines did a great job at identifying early on that this case was going to be a high dollar claim And I believe by being proactive through early identification and intervention, we worked together to ensure costs were controlled and secured early on to avoid any big surprises, once that bill arrived.
Yeah, Fiona, I know a little bit about what you do, but I'd like to hear more on it because I'm not as familiar. So when you get a case and there's no bill, you don't have a bill that you can look at and say, okay, this is going to cost me $50 for the Band-Aid, so I'm going to pay you. How do you approach that when you have no bill? What is, when you pick up that phone and talk to the CFO, what kind of payment are you talking about?
We do have various tools at our disposal for cost of care. So we believe no claim is too big, nor too small, nor too complex. And we know there's no one size fits all approach to cost containment. We utilize various cost containment strategies through what we call a blended approach, or combination of networks, contracts, negotiations, to name a few. We have a great team of negotiators from our first level negotiators to our in and outpatient team for high dollar claims, and a complex claims unit, which I'm proud to be a part of, who are well versed in complex catastrophic claims. In this case, although we secured a deal on the upfront, we still have a due diligence to review the bill once it arrives to ensure it's free from coding errors, duplicates, or excessive routine items. Our negotiator ensured that we received a copy of the UB and itemized statement, that 100-page document that often accompanies a UB or facility bill. I can definitely speak for the complex claims unit when I say we love scrutinizing a big bill and itemized statement. The itemized statement actually tells the true story behind the charges on a high dollar claim. We have a great itemized tool in-house that allows us to efficiently review the 82-page itemized, in this case, at the line level to ensure the bill charges match services rendered. In reviewing the bill, there were no coding errors. The DRG build was DRG 356, which is other digestive system OR procedures with major comorbidities and complications, which was the appropriate DRG in this case. The majority of the bill was for room and board, ICU, OR charges, and clinical labs, which accounted for approximately 63% of the total bill charges, which is typical for this particular DRG. And in addition to some of our tools, I believe experience matters and has a huge impact on how we do what we do here at Global Excel.
Absolutely. Just listening to you, I think I can hear a lot of the experience and the skill that goes into this. It's more almost art than science, or at least a nice blend of the two. Maybe one more question for you. How much was the bill when we finally got the bill? How much was that bill?
When the bill was received, it was nearly $1 million. But our negotiator was actually very proactive in working with the provider in this case to validate the DRG code. And when I speak DRG code, it's the code that Medicare uses to group and assign reimbursement for inpatient admissions that would be actually billed. So this knowledge actually did allow us to benchmark properly and guide us in determining the true value of services and ensure that we secured the best deal and right discount prior to the bill arriving. But in the absence of knowing that DRG, where we were proactive in this case, we do rely on experience, and we have tools in order for us to estimate possible DRG codes and then to benchmark against Medicare and other industry standard benchmarks. But our negotiator was great in this case in validating that DRG code to ensure that we were securing the best discount. And the end result of the early negotiation, it was a 84% discount, significant savings in excess of over $800,000 compared to the typical RAP network discount that Sharon mentioned earlier on. It was approximately 50%. And something that we speak to often is that true cost containment is not about just getting any discount. It's about getting the right discount. and one that represents true value. And in this case, that 84 discount was also, it also equated to 1.3 times provider costs, so real value, which of course has a positive impact on our client's bottom line, but it's also something that we are very proud of as well.
Yeah,
in the art of
absolutely.
negotiation.
Absolutely. If I hear you correctly, so that you're looking at several different points of comparison to understand that in this case it was a hospital, what the provider's costs are, what a fair reimbursement might be on several different benchmarks, and then having a conversation in the absence of a bill around paying based on a benchmark, based on some sort of fixed rate reimbursement, as opposed to a discount off of charges that, you mentioned it's an 84% discount. You only know that once there's charges to know that. But at the time that you negotiated, you're saying this is a fair markup above your actual cost, and then it translated into a phenomenal discount. So, I guess the biggest question I have now for the group, and I'll just kind of throw it out there to everybody. Fantastic. Each of you talked about from a different angle how all of this works out, but how does it interplay? I mentioned the cracks in the system on the healthcare side before, as you transition from one level of care to another. I think of in a normal setting or a standard setting, you would have a company doing your URCM. You might have a separate company looking at it from a medical perspective, from a CMO kind of review. You might have another company that does your out-of-network processing, and you might have a third company that might do some negotiations, or a fourth company that does some negotiations. How exactly does it work with Hines? How did all of this kind of piece together?
Excellent. Yes, well, with case management, between utilization review, the case manager who was initially assigned, the oncology case manager who came on briefly, the work that was done, the detective work, the work to get that coordination of benefits paperwork through, so the claim could go smoothly to our negotiation team, not get hung up. All of those layers as we're going back and forth, accessing them, our medical team for medical reviews, coordinating the care through all the departments was crucial on this one to have the effective result we achieved. Not only the cost savings through the negotiation, but helping this family maneuver just truly what was a tragic circumstances with these multiple diagnoses coming at them on literally every day. Something worse was going on. So to have that emotional support through all of it, and questions answered and education provided, really enabled this family to spend those last few weeks of this patient's life in the setting they desired, with her pain controlled and her symptoms managed.
And from the perspective, if you don't mind my jumping in, from the perspective of a physician on the floor, when there is this kind of support, it makes a big difference, because people actually get left behind in the hospital sometimes. You're done, you want them to move, but then they get stuck. And if it hadn't been for what Hines did of making sure that the benefits were coordinated, the Medicaid came in to help with the nursing facility, all of that makes a huge difference, because I've seen patients just get stuck on the floor and we're done with them. We have nothing to do, but they're still there and they're not getting the appropriate palliative or nursing care they need.
Absolutely, Ferial. In this situation, the Medicaid was secured early during the acute hospitalization, but was accessed when she did choose the hospice path for end-of-life care. Medicaid was able to pick up that long-term care setting and help the family avoid that out-of-pocket cost. But she could return to that same skilled nursing facility, but under Medicaid for those last few weeks.
So that's a bit of a savings right there too. And then in addition to that, there would be no way that that family was going to figure that out. Waiting for a social worker to apply, to do this, to do that, or whatever. I mean, it's totally impossible. So kudos.
Yes, it was a complex situation. You know, we're seeing short staffing in virtually every provider setting today across the nation, and this was a case where that occurred in the skilled nursing facility. And when she transitioned to hospice, the family continued to reach out to the case manager for assistance because she would have escalating symptoms. Her pain was uncontrolled. Case management was very effective in advocating for this patient, helping that palliative care be approach during the skilled nursing confinement, and actually increasing the level of hospice care those last few weeks. So they prevented a readmission at that point to an inpatient hospice. The family voiced great appreciation during the course of the case, commented multiple times to the case manager that she was the only one who cared. We hear that when families are just lost in the system. This is complex, confusing, and they don't know where to turn. So to have that one person who can help provide some continuity of understanding what's going on and to collaborate with all these providers who are working so hard but are short staffed, it really does benefit the member in the end.
Absolutely. You mentioned that the family and the appreciation that they had, and you can easily get caught up in a medical system where the focus is on, what are the vitals, what are the lab measurements today, and they focus on making sure that everything is going on, but don't necessarily have the time. And to hear that Hines has the time to stand there beside the husband and walk him through and educate him on what's going on and how that's going to progress, it speaks volumes to the human side. I always think of what we do as kind of a three-legged stool, if you will. There's definitely a cost component, and Fiona spoke to us about that, and what happened with the hospitalization, and even just avoiding costs. And Sharon, you touched on some of that, how we properly stepped down and we transferred from one setting to another setting. And obviously there's the medical side, and this was a very complex. Farrell, you spoke to just incredible care that was provided because she was in a really, really bad situation. But the third component, that caring component, if you put everything together, there really is, it makes a very solid base from which I think we can deliver the services that Hines provides. And in this particular instance, we're talking, if you look at the care that was administered to the patient, I think the best possible experience in a very unfortunate situation. And if you look at the financial side of it, if I put my stop loss carrier hat on, for example, and you think about, well, we probably avoided, a couple $100,000 in care just by making sure that the step down happened appropriately, that didn't end up going to SNF and then reverting back to a hospitalization, instead went through the proper steps to make sure that they got there, avoiding some of the costs through some of the Medicare coordination, Medicaid coordination. And finally, there's obviously there's $1 million bill that came out, and we saved another $800,000 there. Financially, I think the outcome was the best possible outcome as well. It's incredible the work that you do, and I don't know how to thank you enough on behalf of the employer group, the TPA, the stop loss carrier that was involved, and most importantly for the family for walking through what could have otherwise been, just an absolute nightmare. And I think you probably made that a much smoother and easier transition for them. So thank you all so much for taking time today, talking to us about this case and sharing some of that with us.
Thank you.